You heard the introductions, but please read the bios of these physician leaders and advocates. They have dedicated their lives to instilling change in our community and seeking healthcare equity. So let's learn from them. So first, Dr. Robinson, good morning.
Good morning.
I would like to direct the first set of questions to you. We are stunned by the revelations of the past panel on homelessness. Not only are you a family physician and chair of the USC Department of Family Medicine, you also co-founded the USC Street program many years ago, 6 years ago, actually. How does the intersection of economic inequality, housing instability, and health inequity uniquely affect the Black population in Los Angeles? 2, what solutions or initiatives are being proposed or implemented to address these interconnected issues?
Thank you, and I'm delighted to be part of the panel this morning and be with all of you. We founded the USC Street Medicine program in 2018 because of the significant health inequities that impact our unhoused community, which we've heard from our previous panels is overrepresented by Black people. And we felt like we had to stop waiting for people to come to us. We needed to go to them. And so USC Street Medicine brings primary care to people on the street, people like John, who's a patient of ours. He is a 60-year-old man with a history of high blood pressure. He has emphysema and chronic back pain. He lives at a bus stop. All his possessions are in a grocery cart, which serves to store them, but also is a mobility aid for him. Because with his chronic back pain, he can't walk very far, so he uses the cart to help him. Across the street, there is a fast food restaurant, and that's where he's able to sometimes get water or use the bathroom if the employee who's there will let him do that. We knew that John, although he has Medi-Cal, was not, and although he lives at a bus stop, was not going to get on the bus and go across town to be able to see the primary care physician that he was assigned to. He was focused on basic survival needs, trying to get enough to eat, trying to make sure that his things don't get stolen. So I think, jumping to some of the challenges, we know that people die 25 to 30 years earlier if they are chronically unhoused compared to those who have stable housing. And our goal for USC Street Medicine was to bring high quality primary care. And what is high quality primary care? That's care that is, number one, accessible to the people who need that care. Number two, provides continuity so we can provide trusting relationships and be able to build and develop health over time. Number three, it's care that's comprehensive. We can take care of John's emphysema. We can get him his vaccines to prevent flu and COVID. We can take care of his mental health issues, the depression and anxiety that he suffers. We're also able to offer care for people who have addictions as well. So that comprehensive nature is important. And finally, we have to be able to do care coordination. So when John needs to get to the emergency room or to see a specialist, we go with him, because otherwise we know about the discrimination that he will face because of being in poverty, because of his homelessness, because of other factors. It's critically important that we are there to accompany them. We know that people who have access to high quality primary care, our studies have shown this time and again, live longer than people who don't. And so what we're trying to do to address these significant health inequities is to bring care to people where they are.
Dr. Toqui, good morning.
Good morning.
Good, I want to follow up with you. When we dial down, we see a significant number of persons who are unhoused or with housing instability, living with HIV and or hepatitis C. This speaks to a larger picture regarding HIV prevention and treatment and this endemic of STIs. So STIs are sexually transmitted infections. So Dr. Toqui, we want to ask you, why is this happening? What are the social, economic, and systemic factors contributing to the rising rates of STIs and the disproportionate incidence and mortality of HIV among Black and Latinx communities? And how can we improve their utilization?
Yes, thank you for having me. I'm glad to be a part of this event. It's pretty clear that there's a direct correlation between homelessness and equity, and in regards to the high rates of HIV that exist amongst our key populations, Black and Latinx, you don't have enough resources, you don't have the education. The education is really key in terms of making sure that you make the right informed decisions for your health. And so it's just a snowball effect in terms of not having resources available to be able to combat your health. You don't have the right access in terms of people navigating to help you get to what you need to get to. Excuse me. Being diagnosed with HIV, you're taking in a lot of new information. And a lot of times you already don't have the medical background, or at least the baseline knowledge to comprehend the diagnosis in itself. And so with that being said, you don't follow up. So we tend to lose patients, and that's what we see. So with our organization, the providers are counseled on making sure that they provide a lot of education around the diagnosis. We make sure that we have a lot of resources available to our patients. We have our referral coordinators, we have therapists on board, because it becomes a holistic approach for this patient taking on a diagnosis and already having issues with resources, housing, food insecurity, and so on and so forth. So what we really try to do is target our patients and provide a holistic approach so that they're able to go through the process of not only taking care of their health, but getting those resources to get a roof over their head, having the resources to find food, and then from there on make informed decisions, because at the end of the day, if you don't have these basic foundations, you're not interested in taking your medication. Right? So that is where we come from in terms of when we capture our patients and try to retain them so that they can get to where they need to go to with their health.
Thank you very much. Dr. Batchelor, I don't have far to talk. Good morning. As CEO of MLK Community Healthcare, serving one of the most underserved areas in Los Angeles, please help us understand the mission of MLK Community Healthcare and how that mission translates to a passion to serving our community. What do you see are the most pressing systemic barriers preventing equitable health care for Black and marginalized populations in Los Angeles?
Thank you. Thank you for having me as part of the panel as well. The mission of MLK Community Healthcare has two parts. One part is to provide compassionate, high-quality care for our patients, and the second part is to improve the health of our community. And to do that, we need to reach outside of our hospital and outside of our health system into the larger community. I'd like to focus on three areas where I think we need to make progress in order to address health disparities. The first is ensuring that the providers who are caring for our communities have adequate resources. The second is ensuring that we have effective and robust performance measurement and accountability systems in place. And the third is diversifying the healthcare workforce. I recently co-authored a report called Ending Unequal Treatment that was recently published by the National Academy of Medicine. In that report, we note that inequities are designed into the very systems and structure of our healthcare system. And if we want to have a more equitable system and more equitable outcomes, we have to change the system and change those structures. Healthcare policy is a good place to start in talking about systemic change. Many people in our communities rely on Medicaid insurance for their health coverage. We've done a good job in California and nationwide in expanding the number of people who have insurance coverage through Medicaid. But in the process of doing that, we've created a system, a program, that has huge gaps in quality and access. Medicaid pays providers significantly less for the same services than other insurance programs, and often pays them less than the cost of providing that care. That means that providers who care for our communities don't have the resources they need to provide that care that she described as accessible and high quality. But we know that policies that are designed and enacted can be changed. We can change Medicaid policy. Reimbursements for providers should be increased in the Medicaid program so that providers are getting paid the same as other providers taking care of other patients, and at least as much as providers working in the Medicare program. But to do that will require a commitment to equity and political will to make those changes happen. In addition to adequate resources, we need robust accountability systems. We have a lot of measures of healthcare quality and access, but we don't consistently use those measures to hold providers accountable for their performance. For example, every hospital that participates in the Medicare program is required to report quality and access data to the federal government. That data should be stratified by race and ethnicity. It should be used to incentivize and guide care improvement. If we want more equitable care, we need to have stronger systems of accountability. And then third, we need to diversify our workforce. There's a growing body of research that shows that outcomes for healthcare are related to the match or mismatch between providers and their patients. For a variety of reasons, including some that we've already touched on, such as trust and bias, we get better outcomes when there's an alignment between the racial and ethnic background of providers and their patients. But we also know that there aren't enough providers of color. So what should we be doing? We should be investing in encouraging more young people, a more diverse group of young people, to enter the health professions. Government could subsidize the high cost of professional education. Government could do a better job, a more equitable job of funding training programs in hospitals like mine, in communities where we actually need the healthcare workers. We have a 1,500 physician shortage in the community of South LA where I work. And despite that shortage, hospitals in other parts of the county, like in West LA and in the South Bay, receive 3 times as much as we receive for every physician we train. And that is designed into the system of federal funding. So we need to make these systemic changes if we want to have a more equitable system. And in our communities and among our providers, we should demand those changes.
Thank you. Thank you very well. Well said. Dr. Shah, good morning.
Good morning.
We need data. We need data that we can rely on to answer our questions, to support our hypotheses, and to drive policy to implement change, just like Dr. Batchelor just talked about. How are you and your team at DPH utilizing data to identify and understand acute and chronic diseases that create systemic healthcare disparities?
Thank you for your question, and thanks for having me here. I'd love to talk to you about data, and I'd love to take a step back from specific diseases and actually talk about healthcare data. And specifically, I want to share medical debt data and what we're doing on medical debt. I'll start by saying we have more than concepts of a plan. Sorry, couldn't help myself. Medical debt is a public health problem here in LA County, and it's a priority problem. 1 in 10 Angelenos has burdensome medical debt, not just any medical debt. That's more than smoking, that's more than asthma, it's on the same level as diabetes. And beyond the numbers, which $3 billion of medical debt, stark disparities with Black Angelenos having 50% more medical debt than white Angelenos, beyond the numbers, beyond the impacts on physical health, on future healthcare, on mental health, on food security, on housing security, I just worry about a world in which healthcare, which is often phenomenal, often brilliant, often awe-inspiring, can harm instead of healing. I really, really worry about that. And I worry about its implications on social trust, not just an individual's patient's trust with their provider, which is so important, but really healthcare as a social pillar in our democracy. If it's harming us, what do we have left to stand on? I worry about agency. A lot of the healthcare harms that we see, including medical debt, as we've heard today from so many different people, and even just before I was talking with Dr. Scorza about a personal story he's recently had. Agency is, the flip side of social determinants and structural barriers. Our policies need to address structural barriers and social determinants, but somewhere there, the language of agency is missing. The idea of agency is missing. I think agency is key to dignity. And the reason medical debt has so much resonance in anyone I speak to is because it represents so many successive losses of agency to get to that point. In terms of what we're doing, though, two key things. The first, I'll talk about local partnerships. And while state and federal actions are important, there's a lot we can do here right now in our community with our resources, our authorities, and our innovation. We have a medical debt coalition of more than 40 different organizations, everyone from community-based groups like Rising Community and One LA, advocacy groups, American Cancer Society, hospital leaders like Dr. Batchelor, health plans, government agencies. And this coalition has informed, it's enacting our work, and it's been incredibly powerful. Some of those partnerships, we're reforming financial assistance, improving financial assistance policies and applications so that we don't just have great policies on paper, but we actually put them into practice. We're requiring the reporting and collection of medical debt data, and I think this is going to be transformative. So we're really actually, providing a basis for dialogue, internal dialogue within organizations, and external dialogues with their stakeholders. And we have partnerships to both retire medical debt and then other efforts for patient navigation and other tools to prevent medical debt and provide people that trust an agency back. The other side of partnerships, though, that's really important is leadership. Without leadership, we wouldn't have these partnerships. We've had to have individuals step outside of their personal and organizational comfort zones to really be a part of this coalition. We've had organizations and individuals bear cost for doing better. And this leadership really matters. It's why this, I think, venue is so important. All of you are leaders, and you're doing it in an open way, in a way that encourages and inspires others to be leaders. And I really, really want to particularly thank, Supervisor Hahn and Supervisor Mitchell and all the supervisors who have passed a number of actions on medical debt, but also, forgive me for putting you on the spot, but I'm an incredible fan of MLK Healthcare and Dr. Batchelor. We've worked together for several years from the COVID pandemic when they had to house multiple patients in their gift shop because South LA was so overloaded. They were the most burdened hospital, not only in the state, but possibly the country. From Mpox, that emergency when MLK Community Hospital took care of some of our sickest Mpox patients in the county. They're not a tertiary academic medical center, but they roll up their sleeves and take care of whatever's needed. And personally, I think beyond the quality and compassionate healthcare, we need this kind of leadership that does the advocacy to really shift power by changing the payment mechanisms that create a two-tiered caste system right now. Really, really grateful for the partnerships and leaderships that are letting us address medical debt in all these different ways.
Great. Thank you, Dr. Shaw. Mr. Ford, good morning.
Good morning.
In the 6 years since you were diagnosed with prostate cancer, many advancements in science and medicine have been made, and more continue to appear on the scene. What recent breakthroughs seem most meaningful to you, especially in terms of making the journey less traumatic and less intimidating to those who may be reluctant to be getting screened? By the way, thank you for sharing your journey.
Well, thank you. Thank you for inviting me back this year to serve on this panel again. It's quite interesting to watch the disparity of Black America. The gap gets wider and wider in so many different areas, and particularly in the healthcare arena. We're seeing unprecedented amounts of deaths of African Americans that have been diagnosed with cancer late and are in stage 3, stage 4. In 2023 is estimated to be about 1.9 million people will be diagnosed with cancer. Over 644,000 deaths. Out of that, African Americans have a largest proportion of diagnosis and deaths of cancer, and particularly in the areas of prostate cancer and breast cancer for women, prostate cancer for men. I think that we have to really look at how we can focus on areas of innovation and research to look at biomarkers, the registry, to be able to identify pathways in which we can get early screening, early indications. The advanced stages of cancer at stage 3 and 4 must be addressed much more aggressively. There has been policies that are put in place right now. In the Senate, Senator Cory Booker is marshaling a bill called the HIM-AC. And what that is doing will eliminate the copay for men who have to undergo a prostate exam or a PSA. That will help eliminate a barrier there, but much more is needed to be done in research. And what I have found, one of the innovative approaches with addressing prostate cancer is with Oxford Biodynamics. They have come up with a blood test called EpiSwitch PSE. With a biopsy, well, with a PSA and a PSE, it improves the accuracy from 55% to 94%. Now, I'm going to use, say, my Uncle Sam. Lives in a little small town in Ohio, and he can't get across the road to get to the doctor, but he's got someone coming to his house to do his blood test. Well, that eliminates a lot of time and gives the physician a real look to see, well, okay, we may have to do a biopsy now because this test is showing his PSA levels are high, his Gleason score, to be much more aggressive. But we've got to continue to find a pathway through innovation, technology, patient support, advocacy, as well as allyship with organizations such as the Urban League, such as Brotherhood Crusade here in Los Angeles, or GLAC, to put on these types of symposiums that people can get information and be much more aware of the need to really bring about these discussions and let us find a pathway to do something about it. We've got to turn our pain into a purpose with passion. We have to do that. We have to do that. I've experienced from a personal journey, not only with myself, with my son. Back in 2019, he lived in Tennessee, and I went down to visit him. And I discovered that he had really a difficult challenge walking, and is a lot of pain. And he had been underdiagnosed by the medical group there in Tennessee. It turned out that he had severe rheumatoid arthritis. I brought him out here to California where I knew that he would get proper care. After 2 knee replacements, he's back to working. He's still not out of the woods because he has to be on a medication to control his rheumatoid arthritis. But to watch him struggle and to watch him go through that, my own experience told me that advocacy is so important, so important. We've got family members, uncles, aunts, fathers, mothers who need us to go to the doctor's office with them. They need our support. They need our help. And through organizations like the American Cancer Society, there are many areas in which they utilize their resources to help with patient navigation and patient support. Someone needs a ride to the hospital. Someone needs a ride to the doctor's office. Or, we have a Hope Lodge in different parts of the country where a family member can stay or a patient can stay while they're getting treatment. Any types of resources that help with navigation and patient support is critical, is very critical.
Great. Thank you. I want to move to potential solutions. So Dr. Robinson, Dr. Batchelor, you're both deeply involved in training and guiding new healthcare professionals. How do you believe medical education can evolve to better equip practitioners to address and dismantle the social determinants of health affecting marginalized populations?
I'll let you start.
Sure. I can start in just really building on what Dr. Batchelor said earlier about how important it is that we are addressing the inequities in who our physicians are, right? Less than 6% of our physicians are African American. We have to do something about that. So being involved in medical education is absolutely critical. What we've done with our USC street medicine team, once we got our teams up and running and felt like we had a good process, we started adding learners. We train PA students, we train medical students, our family medicine residents go out on the street with us as part of their education and training. Partly it's because we need more folks to do that work in the future, but I also believe that everyone needs to be exposed to that. We learn so much, and I will share briefly a story of one of our interns, Ron, who I brought out to the street last week when we were on street medicine. And he's a fantastic intern. But he was able to learn so much from a patient of ours that needed, who had an abscess that needed to be incised. And I talked Ron through that process, and we engaged the patient every step along the way. You know, what are the options for treatment? Do you want to go to the emergency room? What would you prefer? How do we do consent? Talking about the risks and the benefits and all of that. And what was a beautiful thing is that the patient also brought their lived experience from the street. He said, let's go sit over in the shade, because it'll be cooler over there while we're doing this. And as we started to do it, and we explained every single thing we were doing, asking permission every single step of the way, he said, hey, I think there's a spot over here that you need to get. And I'm like, all right, is it okay if we open it up a little bit more? He said, that's fine. So this kind of process, we have to bring our learners along with us. One other specific thing we're doing at USC for the students who are not yet clinical is we have a Trojan trainer program. So we take first and second year PA students, first and second year medical students, and we pair them with one of our patients who becomes their trainer. And they have a longitudinal experience with that patient who teaches them about what it's like to be homeless. And the students figure out how they can help. They celebrate birthdays, they bring art supplies, sometimes they help to get a license for a patient who may need one in order to be able to apply for a program. So I think we have to engage our students. I love what Congresswoman Waters said earlier about the young people and the brilliance, and how do we bring that into what we're doing and be able to have everyone benefit from it.
So I'll echo what you just said, which is twofold. One is we, again, need to diversify the healthcare workforce. So we need to support young people in studying math and science and in going into healthcare careers, becoming doctors and nurses and other types of healthcare professionals. We need to make sure that students are exposed to not just the science and the medicine, but the social and political determinants of health as well. And what you described, is taking our students out and letting them see that patients exist in a social context, and that they need to consider that social context, and that our health system exists within a political context. And we need to think about how that political context, it needs to be changed as well. And we need to work on all of those fronts if we want to be able to bring equitable healthcare to our communities. So I couldn't agree with you more about that, and love the story about the street medicine team.
Thank you. So we're about 8 minutes left here. Dr. Tokri, given your local, national, international experience of HIV management among vulnerable populations, what key strategies have you found most effective in bridging gaps in access to HIV care and prevention, and particularly for marginalized groups? I really want the audience to hear that we can stop new HIV diagnoses and incidents in our lifetime, that we have the tools for that.
Yes, thank you. So I spent some time in Zambia. I lived there for approximately 2 years, practicing infectious disease and HIV care. And what I noted in terms of similarities is that they really involved the community in terms of making sure that education was paramount so that patients could be aware. They employed community health workers to go out into the communities after going through training and getting educated about HIV to foster trust amongst the community members, because a lot of times when you come in and you're foreign, the knowledge that you impart on them for health may not be taken up. You have to understand the culture. You have to understand the verbiage that they will, be able to gather from what you're trying to tell them. So in doing so, what Zambia accomplished was 90-90-90. And that is 90% of patients who are diagnosed, they know their status. 90% that were diagnosed are on treatment, and the other 90%, they're in care, they're retained in care. So I see this parallel with AHF. We also incorporate community health workers for retention. That's a big part of helping combat the HIV rates, preventing new cases. Patients that are retained in care and they're on their medications cannot infect anyone else. So that is really, really important. And a lot of people are still sort of unaware because of the stigma that surrounds HIV and AIDS. And AHF has been around since 1987 at the forefront of the AIDS epidemic. And now we've moved to 46 countries whereby we're really being able to impact patients and provide medications to patients so that we can really target the HIV rates. And we're doing the same thing in the States. And so the big part of it is we work with tiers. We have our community health workers. We have our linkage teams. They go out and they link new patients that are diagnosed into care. We also have pharmacy sales reps that go out and they look for our patients that have been out of care for more than 12 months. And so all of this helps towards the efforts of retaining patients, providing access, bringing them into care, getting them on medications. The other part of it is PrEP. This is pre-exposure prophylaxis. We're doing both things in terms of advocacy because for those patients that are high risk, they should know their options. They should know what's out there to prevent them from contracting HIV. That's the other side of it. So a lot of education is involved, a lot of counseling. We need to continue to have this at the forefront and make sure that our providers, whether there are medical doctors, our nurse practitioners, our physician assistants, they're all aware of how to be culturally competent when they're delivering the education around HIV. So this is paralleled with what's happening in sub-Saharan Africa. And I just say that having and incorporating all of these different tiers in HIV prevention and treatment will help us as we move towards the goal of lowering the new cases of HIV.
Fantastic, thank you. So in the minutes that we have left, Dr. Shaw, how does the Department of Public Health ensure equitable access to essential healthcare resources and medical countermeasures so we're not left behind when we have emergency situations or things as Dr. Ferrer had mentioned during the pandemic?
Yeah, so, I was helping to build our COVID-19 vaccine rollout in December 2020 when the vaccines first hit the county. And it was really sort of back to residency hours, if you remember, 100-hour weeks for months on end. And we could not have done it alone. And I'm going to reiterate what I said during my remarks on medical debt, which is partnerships and leadership. It is partnerships and leaderships that got us our results here in LA County. And in a county of 10 million, of 80 plus cities, of 4,000 square miles, of such diversity, we need different strategies for every inch of the county. And you cannot, as one organization, create all of those strategies, hold all those relationships, and do it alone. So one of the things we deliberately did is we prioritized efficiency and equity in terms of access. We had about double the density in February of 2021 of COVID access points as any other California county. And that's to bring more people in so that they could reach their patients, their communities, the populations they knew well, better than we could. It was a lot of work. It was a lot of extra work. I think a lot of people, opted for a strategy which said simplify, deal with less, and maybe that works in certain regions. It does not work here. Fundamentally, I think in order to enable those partnerships, though, if we look at the underlying structures of power, right? We're public health. And we always want to look upstream. We want to look at prevention. And power in healthcare flows from the dollars in healthcare. And as Dr. Batchelor, highlighted, the way the dollars flow, there really is a two-tiered system. And until we address that, we're always going to just be doing a little bit of extra work on the back end to try to make, a terrible situation a little bit better. Just in terms of leadership, we saw leadership really emerge out of the woodworks during that time, and that was actually incredibly promising. Organizations, one of our highest vaccinating sites was here in South LA, Kedron Community Health Centers. They're a small federally qualified health center and an acute psychiatric hospital, and they became a vaccination superstar. Would not have expected that. I received a call at 11 p.m. one night, I still remember, from Dr. Abraham, who works there. And I think it's just, again, partnerships and leadership.
Great. We had some amazing stories during that time period of Dr. Abraham calling us up at 11 o'clock at night or 2 o'clock in the morning and saying, we have vaccines. Get your people down here now. So we called frantically to get people down there. So you're right, community partnerships. Mr. Ford, we have about 30 seconds left. Please bring us home. Talk to us about community partnerships, how they're important, and the ways of addressing healthcare inequities.
Okay, thank you. Real quickly, I think the partnership has twofold with local community-based organizations and corporate America. We're up here talking about healthcare, but we also have to tie in environmental justice and climate change. I was sharing in back before talking about the impacts of what these hurricanes are having in Florida and other parts of the country, and wildfires that we're having at an unprecedented rate. The lag time in now going to see a doctor, be able to connect with somebody in the medical field if you have asthma, heart disease, diabetes, or kidney, you're on dialysis, let alone if you're in stage 3 or stage 4 cancer. We've got to find a pathway to reduce the fossil fuel emission rate that we're seeing. You've got 2 major freeways, 710 and 605, where you're seeing from the ports of LA, 40% of the goods movement is part of the diesel trucks coming in and out of the ports going into the other parts of California.
Mr. Ford, I'm so sorry. We have 11 seconds.
Okay. We've got to make sure that we are studious about the environment and be caretakers of this earth.
Fantastic. Let's thank our panelists, please.
Yes, thank you very much for participating, all these panelists. Thank you very much. And we are now going to take a quick break, just 5 minutes. We do ask you to be back shortly because we will have Los Angeles Mayor Karen Bass with us. 5 minutes.